In this final segment, we will continue building on previous concepts by reviewing valvular heart disease, pericardial pathology, vascular physiology, and complications related to cardiac devices. These cases will help reinforce pattern recognition and clinical reasoning. Case 7. A patient presents with an opening snap followed by a low-pitched, rumbling diastolic murmur best heard at the cardiac apex. This is characteristic of mitral stenosis. Mitral stenosis is most commonly caused by rheumatic heart disease, especially in patients from Latin America, Africa, or Asia. The opening snap occurs due to abrupt opening of a stenotic and calcified mitral valve. This sound is followed by a diastolic murmur caused by turbulent flow across the narrowed valve during ventricular filling. On the left ventricular pressure volume loop, this event occurs at the end of isovolumetric relaxation, when the mitral valve opens. This corresponds to the transition into diastolic filling. Case 8. A 28-year-old man presents with a 3-day history of chest tightness and intermittent sharp chest pain. He also reports mild dyspnea, especially with exertion. He has no chronic medical conditions but had a recent upper respiratory infection that resolved without treatment. Electrocardiogram shows sinus tachycardia and low-voltage QRS complexes with variation in amplitude, known as electrical alternance. The diagnosis is viral pericarditis complicated by pericardial effusion. Chest X-ray may show an enlarged cardiac silhouette with clear lung fields. Pericardial effusion can be caused by acute pericarditis, cardiac injury such as myocardial infarction or surgery, malignancy, or renal failure with uremia. Clinical features include dyspnea, chest discomfort, and fatigue. In severe cases, cardiac tamponade may occur, presenting with hypotension, jugular venous distension, and decreased heart sounds. A patient receives acetylcholine during a procedure, resulting in dilation of epicardial coronary vessels. The correct answer is arginine. Endothelial cells respond to acetylcholine and other stimuli by increasing intracellular calcium levels, which activates endothelial nitric oxide synthase. Nitric oxide is synthesized from arginine, nicotinamide adenine dinucleotide phosphate, and oxygen. It then diffuses into vascular smooth muscle cells, activating guanylyl cyclase and increasing cyclic guanosine monophosphate levels. Elevated cyclic guanosine monophosphate activates protein kinase G, leading to decreased intracellular calcium and smooth muscle relaxation, resulting in vasodilation. Case 10. An 82-year-old man presents with fatigue, abdominal discomfort, and lower extremity swelling. He also reports a pulsating sensation in his neck. 6 weeks earlier, he underwent pacemaker implantation for sick sinus syndrome. Physical examination reveals bilateral lower extremity edema and a tender, pulsatile liver. The most likely diagnosis is tricuspid valve regurgitation due to mechanical disruption caused by the pacemaker lead. The lead passes from the superior vena cava into the right atrium and across the tricuspid valve into the right ventricle. This can interfere with valve leaflet coaptation or directly damage the valve. Severe tricuspid regurgitation leads to right-sided heart failure, characterized by jugular venous distension, hepatomegaly, ascites, and peripheral edema. On auscultation, a hollow systolic murmur is heard best at the left lower sternal border. This murmur becomes louder with maneuvers that increase right ventricular preload, such as deep inspiration or leg elevation.